COVID-19 and those who are at the background designing solutions to problems is the importance of thinking across disciplines. So this is very important, and at AIMS we are very keen to attract people with this kind of mindset. The method is free of charge. We're making it available to the public, to humanity, free of charge. We really want to be catalysts of human progress in Africa and outside the continent. So currently countries that are interested in using this method to test their citizens, their residents, are free to contact us, and would support them as much as possible to deploy the method in their countries.
Oh, here we go. We had mentioned that at one point during this event we might have some technical issues. I didn't know I was muted the entire time, but I guess we're good to go. Thank you very much for joining us. We are on day 2 of the Next Science and Forum Global Gathering 2020, the virtual edition. We've had a lot that we've gone through so far, and today we're just going to pick up the momentum from yesterday. Now, yesterday we did mention that we have our social media presence, hashtag NEF2020, and the handles are at NextEinstein4 and at AIMS_next. So a lot of you have been tweeting, and a lot of you have been putting the hashtag. I know the official hashtags have been doing so.
The reason why infectious diseases like COVID-19 spread very fast is because if somebody gets infected, they infect more than one other person, and that person infects more than one other person. So the disease grows exponentially in the population. But if you can catch that new infection fast before it gets the chance to cause another infection, the disease disappears. To approach this level of testing, you need to sample people intelligently and test, and you need to do it regularly, quickly. What we have done is develop a method that can improve the capacity of countries to test massively and regularly at lower cost. And when you do that, then you can quickly stop new outbreaks from spreading within the community and eventually cause the disease to disappear.
That mathematical model, it's a model using hypercubes where you can just make a mix-up of the samples before you test them. And then you minimize the cost and also the time for reporting the result. And we were trying just to propose something which will be convenient for the country for massive testing, for community testing. And then we validated this approach in our lab here. We used to have an average of 1,500 samples a day. We used to have like a quick feedback within 48 hours. Now with pool testing, then it is very quick. Within a day, give the feedback from the patients.
The reason this hypercube does better is because minimization problems generally favor symmetry. So let's imagine we had 2 infected individuals, and they're located at these 2 points of the hypercube. Well, the slicing in the X direction would capture those 2 points on different slices. But the slicing in the Y or the Z directions would capture them on the same slice, so that would be degenerate, and you could not uniquely identify their coordinates. However, if these points happen to be arranged in this way, then the configuration is non-degenerate, and every slicing finds the unique value of the coordinate. It's not hard to work out that a non-degenerate configuration has probability 2/3. If we have 3, the only way you get non-degenerate is in a configuration like this, where the points are not on the same slices in each of the 3 directions. But it's easy to work out. This occurs with probability 2/9. So if you slice up your population on all possible slices, and if N and D are large, there will always be many slices which are non-degenerate, and those are the slices you use for the algorithm to work.
This is not the first time we collaborate on this. There are students being trained by AIMS, and some of the students are from the RBC. We are now just trying to make a reflection how to can develop more. There are many countries which are not interested, so Ghana was the first country just to try to apply this approach. South Africa is also behind.
One of the problems we have is that we have people making decisions, prescribing solutions to problems that they don't understand. So we need science because really it is the key to understanding and identifying sustainable solutions to problems. Yeah, so this is a good example of how we can take the maths that we're doing at AIMS to the field and make an impact. We will work to create more opportunities for this to happen. And the fundamentals have to be there. So we need to be training people, and we're going to amplify this effort so that we create more partnerships.
Fantastic. Now we can get things rolling. Professor Jacques, bonjour. How are you doing? See, you're muted as well. You were muted as well. That just shows us that anything can happen on this app, but we'll get things going. Can we hear you now?
It's okay now?
Absolutely perfect. Right. And yeah, I needed to hear you because I know you're about to get on to a very interesting session, but right after I give the intro remarks. So a very warm welcome to everyone joining in. If you're wondering who's that on the top right corner, that's Professor Jacques, who will be taking us through just the opening bits. We have a session with him, and inside a very interesting and very impressive studio. Now, we're at the first ever virtual edition of the Next Einstein Forum Global Gathering, the NEFGG, as was called yesterday by the CEO, Lydia Chizimana, Africa's largest scientific gathering. Yesterday, we had a host of fantastic conversations that happened on this AirMeet video conferencing platform. By now, a lot of you have interacted with it. You've gone to the lounge, you've gone to different parts, you've tested the emojis, the comment section. I guess we're good to go for today. During the opening ceremony, we had a very interesting conversation, remarks rather, by the Minister of Health for Rwanda, Honorable Dr. Daniel Ngamije, who said that the Africans and the country in Rwanda, they stayed ahead of the pandemic, and they will continue to stay ahead and announce the So, of course, a lot of countries are sharing best practices.
Tu me passes le son là? Oui, c'est bon? Okay, because I see that there is some problem of connection. Perhaps I can start the lecture. So first of all, I introduce myself. I am not I am zero in mathematics. I am a surgeon, but what I have to say is that I have always been impressed by mathematics applied to surgery because, you know, our role as academician surgeon is really to invent the future in surgery. Je vois pas l'image de retour, ce qui est extrêmement pénible. Ah, okay. So I want to start and to explain that why I'm so fascinated by science in surgery. That was in 1991. You know that I was a normal surgeon, and in 1991, you see this man. I attended an exceptional lecture. He is a colonel of the U.S. Army. He's a surgeon. And you imagine that in 1991, he had a lecture whose name was Medicine Will Switch from Industrial Age to Information Age. And in 1991, he spoke about all the strengths of internet, of virtual reality, augmented reality, robotics, artificial intelligence, 1991. And so I came back and I decided to create an institute totally dedicated to this kind of science applied to surgery, to the concept of augmented surgery. And I think the idea I had at this period, that was, we opened in 1994, was to attract not only surgeons, but also a lot of computer scientists, mathematicians, because I am convinced since the beginning that all the development of surgery will be performed by computer scientists and not by the surgeon, because we just use the technology. And that is the example of augmented surgery. Augmented surgery, it is augmented vision. That means how we can have and build a digital clone of the patient to have the ability to see in transparency. So that is number one. So number two is how we can improve our hand, and that is robotics. And the third one is how we can improve the strategies during the operation, before, after the operation, and that is the development of artificial intelligence. So we start by Augmented Eye very quickly, and we have a team of 32 engineers, developers in this kind of specialty. And you see that we take the image, the medical image that you can see here in black and white, very difficult to understand, and with some software, we have the ability to transform this image in a 3D image. And this 3D image is so realistic that we understand all the details of the anatomy of the patient. And you understand that that is the best way to prepare a good operation. We can do that for all the organ. Here, for example, you see this huge tumor in a baby of 2 months old. It is what we call an hamartoma. No, that is not very important. But what you see is that with a different algorithm, we can navigate inside the tumor. And what we want as surgeons is to see where are the arteries which gives the vascularization, the oxygen to the tumor. And you see very well 2 arteries coming from an hepatic artery. And that was very simple for the pediatric surgeon to operate this young baby. And so it's the reason why we have developed a spin-off of our institute, IRCAD. And you see, everybody can send a normal CT scan or MRI, and we can transform in 3D. And today, with artificial intelligence, what we were able to do in 2 or 3 hours before, we can do in 2 or 3 minutes. Also, we develop a lot of application. You see, with this software, we can propose a simulation of the operation. That means, you see in green, it's some different tumors. We can propose a part of operation. We can propose an ablation, and we just with the computer know exactly what is the best way to go inside the abdomen of the patient and in the center of the tumor to have a total ablation of the tumor. And finally, what we want is to put together as a fusion the 3D image, which is a 3D image, a digital image of the patient, and the video image given by the camera when we operate the patient. And that is the definition of augmented reality. So just to understand I have just to show again. Okay, so we start just to understand that is a CT scan. You see in green, it is a big tumor of what we call the adrenal gland. That has no importance for you. So we do the first step, we do what we call the planning. So that is the role of the computer scientist with different algorithms to develop this 3D image, what I called before the digital clone of the patient. And you see, during the operation, that is an operation we perform every day. We have the camera inside the abdomen of the patient, and we dissect. You see in blue, it is a big vein going to the heart. And when we dissect, we see exactly in transparency. Here, for example, we dissect what we call the renal vein, the vein of the kidney. And you see in red, in transparency, we see very well an artery that we need to preserve. So just to understand, that is the concept of augmented reality. And I repeat, the progress of augmented reality are the future of surgery, and that is not performed by surgeons, but is performed by mathematicians and computer scientists. Limiting of the factor, it's rigid, it's complex to understand, but you know that the patient has a CT scan, and during the operation, we can have a superposition, a fusion, but the patient moves. He has a lot of movement. You see, for example, that is a dynamic MRI. You see that the liver, which is in red, move, and the movements are more than 5 centimeters. So the computer has to take that into account. And here again, our engineers and developers, they have developed, you see, algorithms, and they put some landmark on the sternum. And with this landmark, they have a predictive algorithm to imagine what is going to be the movement of the liver. So here again, you see, it is your science which is able to have an improvement for the surgeon. And finally, we know also that the first thing we do when we operate, here it's an experimental lab, you see that there is a grasper on the liver, and you see that the first thing we do is to move the liver. So we have a new position, we have a new elasticity, a new position of the vessel, and that is how the computer can understand in real time the new position of the organ. And that is the challenge that we develop now, especially we will speak about with a team in Kigali. The second thing where your science is so important is that we replace the hand of the surgeon by the robots. That is the development of robotics. It was very interesting because we like challenge. And in 2001, we were the first team in the world to do a remote surgery. I was personally in New York, and my patient was in France, in Strasbourg. It's interesting because it was 20 years ago, before the 5G. Today, we have a lot of publication coming from China with the 5G use for the beginning of remote surgery. But 20 years ago, we were able to do that with what we call ATM lines with transcontinental cable. And this operation has been performed in 45 minutes. So that is a historical movie because that was the site in Strasbourg. Just to say, it was not a surgical challenge. It was an information age challenge. That was a lot of cable in the operating room. We have just, the patient in Strasbourg, the setting of the robot. At this period, the name of the robot was Zeus. And so that was in France. And you will see a lot of engineers from France Telecom after that. So setting of the robot now, a lot of engineers in the big area of France Telecom in Paris. And personally, I was in New York in the subsidiary of France Telecom, whose name was Equant. It was not an hospital because no hospital at this period had a line like ATM to allow a remote operation. So that was done from this tower, and we were very proud because it was published in high priority in Nature, and that is very rare for a surgeon who are exceptional to have the possibility to work on that. Second thing, your science is very important for us, is how we can integrate the 3D image in the robotic system. So I don't know if you have seen before a robot. That is a large generation of the robot Da Vinci of Intuitive Surgical Company. And you see that we were able to plug the virtual image, the digital clone of the patient. And when the surgeon look inside the master part of the robot, you see that he is able to see.
Professor?
Yes, there is a problem.
Please allow me to jump in. We're not able to see your slides, if you have any.
Ah, yeah?
Yeah, we would love to see them. I know you've done a good job on them.
Bah oui. And now?
Yes. Now we can.
C'est ce que je t'ai dit. Là, il y a le retour. So you have not seen the slides since the beginning?
Yeah, we've not been able to see them.
Wow. I am so sorry. Mais qu'est-ce qui s'est passé là? So what I have to do? You think I have to show the slides since the beginning?
You could pick up from where you think is the most crucial for us to follow the conversation.
I would say that let's start from the beginning, because this is a very interesting presentation. If you don't mind, Prof. Jacques, to take us from the beginning, because many people really wanted to see your slides. Now we can see.
Okay, I am so sorry, but sorry, because I think it's so important for you. So, mais je t'ai dit que je voyais très bien que c'est pas le retour. Hein. Okay, so just to understand, really sorry. So just to speak about what we do, which is augmented reality, and I repeat, that is your science applied to surgery. So augmented surgery is augmented vision. We need to see in transparency, and that is only possible if we use the different algorithm of virtual reality and augmented reality. It's okay for you? You see the slide now? You see the slide?
Yes, now we can see the slides really well. Yeah.
Okay. So the second thing, it's very important for you is the robotic system. We will speak and show how we can augment the brain of the surgeon, and that is artificial intelligence. So we start, and that is very important. Yes, without the slide, I think it's impossible to understand. That is a medical image. That is a CT scan. But it is very difficult for the surgeon and the physician to understand the CT scan. So we have software by our team of researchers, and you see that immediately we can have a 3D reconstruction of the patient. And this 3D reconstruction of the patient is so easy for us to understand all the details of the anatomy. So that is what we call the virtual reality planification. You have another example. This one is fantastic. It is a huge tumor in a baby of 2 months old, and you see that it is an hematoma. What we have to do before the operation is to navigate inside, and you will see what we are looking for is to see the arteries going to the tumor. And that is because it is the first thing we need to approach when we are surgeon. And you see this one and this one, 2 arteries going to the tumor. For the pediatric surgeon, it has been very easy, because when we imagine this big tumor, we think it will be hours of operation. No, in 45 minutes, it was performed with this possibility of planification. Just to finish, to say also augmented reality. So we have the 3D image, and what we want is to have the fusion between the virtual image and the real image given by the camera. And that is what we call augmented reality. So augmented reality, I just want to, sorry. So augmented reality is this one. So you see we have the medical image. We transform the tumor we want to operate on. And when we see the tumor in green, we can have a perfect analysis of the anatomy. And I repeat, that is only possible because the software allowed us to do this reconstruction. And when we operate, so that is the beginning of the dissection, and we have this possibility of superimposition. But it is not so simple because in the real life, when we do the CT scan and when we operate, you have a lot of movement. So these one are the movement of the liver due to the bracing, and we need to solve this challenge. Once again, it has been possible for the computer scientist team, you see, to put some software on the sternum, and they have developed predictive algorithm to know with the modification of the sternum, what is going to be the modification of the position of the liver. Faudra voir, tout ça arrête mes vidéos. The next one is this one. You see, during an operation, you have a modification of the position of the organ, the elasticity of the organ. So you need to understand how difficult it is for the computer to understand this new position of the organ. Here again, we have a very strong team working on that. And with intraoperative imaging system, we can have a perfect fusion in parallel with the movement of the organ. One word about augmented hand, that is robotics. Robotics, as I said before, we were very proud in 20 years ago to do the first remote surgery. So that was a surgery between New York. I was in New York. My patient was in Strasbourg. Why it is interesting? Because it was 20 years ago with engineers of France Telecom. And today we have a lot of publication, especially coming from China, because with the 5G mobile, it's possible to have this kind of remote surgery. But 20 years ago, it was something very difficult. Here is the video where you see that, as I said before, it was not a surgical challenge, but an information age challenge. And a lot of different, you see, cable setting of the robot in Strasbourg. The robot at this period was the Zeus robot. And you will see a lot of engineers from France Telecom in Paris. And myself, I was in Strasbourg, in New York. So you see the engineers here. So that was really, I repeat, why it is impressive. It is because it was 20 years ago and we had to solve the problem of delay, to have a delay of less than 200 milliseconds, which was totally impossible at this period. And the engineers the success of a delay of less than 132 milliseconds. So that was a building where we were. It was a subsidiary of Equant. And you see the robot. So I was very comfortable in this office of France Telecom and very proud after, because this operation has been accepted in high priority in nature. As I say, another period we need your science applied to surgery. This one is how we can put like a GPS in the operating room. So you see the surgeon is operating on a robot, a Da Vinci robot from Intuitive Surgical. And when he is immersed in the what we call the master part of the robot, he can see the operation given by the camera, but also you see the 3D image. And if he has a 3D image, he has a perfect landmark. So that is really as a GPS in a car. Finally, just augmented brain, that certainly it is your specialty, artificial intelligence applied to surgery. One example is what our engineers and developers, they have done, is to create like a control tower in the operating room. and you see that we can collect all the data, the preoperative image, the external cameras, the laparoscopic camera, the physiological signals given by the anesthesiologist, and all that is stored in the cloud, and we can follow the patient until he is returned to work. And also here, for example, it is a use of artificial intelligence to give an alarm if the step of a surgery are not totally respected by the surgeon. So another application of safety in surgery. I want to finish and to explain that we cannot develop this kind of revolution in surgery if we have not also a training center. And that was IRCAD concept. And we will see that we have also that the plan in Rwanda. So that is a training course. And we use all these new technology to train the surgeon. We have a lot of platform for robotic surgery, and this one will be totally copied to have the same in Kigali in our center. And that is a globalization. And this globalization concept is important because you are involved for the African continent. You see that we start to create IRCAD in France. That was in 1994. And after that, we have another one in Taiwan in 2007, two in Brazil, one in Sao Paulo, one in Rio de Janeiro, and one in Lebanon, in Beirut. And you see that in the middle, we have this fantastic project we are going to see by a short video in Rwanda, and two other projects, one in China and one in USA, the only one which is not signed today. So just to know, it's always the same concept, attract a lot of computer scientists, mathematicians in the center of surgery, because I repeat, the progress of surgery can be done only by your specialty. And always I say one brain of a surgeon plus one brain of a surgeon, it's only one brain and not two. But one brain of a surgeon and one brain of a computer scientist, with that, we can have a progress in surgery. So one word about the center in Sao Paulo, you see, the same, exactly always the same, with education and research. This one in Rio de Janeiro, a deal with a big American private insurance, also the same. That is in Beirut, in Lebanon. And that is your project. That is IRCAD Africa in Kigali. It will be the most important one. You see, with exactly a fantastic African design, which is done by our architect. And it will be a fantastic school for surgery, but also a big team of computer scientists. So that is our area of 32, between 32, 36, it depends of computer scientists in IRCAD France. And always I said, I met in my career a lot of very important people. So we have exactly the same team of research in Taiwan, and that is due to the brain of Liang Chen, who is the science minister of Taiwan. And personally, I met 2 or 3 years ago for the first time, and after that 4 times, the President Paul Kagame of Rwanda. And this personality is exceptional. He's a visionary. He has understood the power of the digital revolution. And that is the reason why, you see, we start a team in Taiwan. We start a team in Rwanda, but the team in Rwanda will be more important in some years, because we will have between 30 and 40 engineers and mathematicians in the next 2 or 3 years. That is a project in China, just to explain, to see that the same in China. 3 hospitals for minimal invasive surgery, 1 institute for research and education. So the same concept. And that is a project in United States, the only one which is not finalized, but just to say that it is a project. So thank you very much for your attention. Si on peut changer les images, s'il te plaît. Thank you very much for your attention. Really, I appreciate this invitation. Why? Because first of all, we have 36 curriculum vitae of researchers coming from Africa for the center in Africa. Always they come 1 month in France, in Strasbourg, to be trained by our team. After that, they go back in Africa, and we have every week 2 or 3 video conference. That means each researcher in Africa has like a godfather in France. And that is a fantastic link between the European continent and the African continent. And we have been totally impressed by the level of these researchers in Africa, hard workers, brilliant brains, and that is due to AIMS, the African Institute of Mathematics and Science, but also Carnegie and Mellon University in Kigali. So I was very impressed and very happy. All the team is very, very happy to have this link, this very strong link between the two continents. So thank you very much for your attention. Sorry for the problem of slide at the beginning. I don't know what happened. And if you have any question, I am sure at your disposal.
I think I just have one question, Stella. I don't know whether I could just go on. There's one concern. So as scientists prepare, right, as everyone prepares to do maybe a similar thing in their country, what do you think scientists should be on the lookout for? Because we have a major issue such as connectivity, for example. Our phones can't connect. So how will we connect when we're talking about surgery, which is a very sensitive issue? The presentation was fantastic, but could we maybe tell scientists who are exploring the same area what they should be on the lookout for?
I think, when I visited Africa, I think that everything that we do here can be totally duplicated in Africa, absolutely, because, it's just a software. It's not very expensive. I know that the transmission system that you have, especially with your mobile, I think everywhere in Rwanda, nearly everywhere you have a 4G. Certainly you will have a 5G. So, the only thing which is very expensive is the robotic technology, but we will have also for education robots in IRCAD Africa, in Kigali. But I think that today to create a team of computer scientists dedicated to image, because it is imaging technology are the most important for the progress of surgery, more than all the different instruments we can have. And that can be absolutely created in Africa without any problem, and especially in Rwanda.
Absolutely perfect. I don't know whether there's anything, Stella, being the host, whether you'd like to jump in, or I could just carry on.
Sorry, thank you, Georgie, and thanks, Prof. So I think we have a lot of questions. We will maybe take 1 to 2, and I will also maybe request Prof. Jacques Maresseau. We have a large Francophone audience, people who can get your English presentation, but maybe just a summary of what you said, a little bit in French, especially your move to Africa. So, Georgie, if you can just go to the Q&A and then take maybe 1 to 2 questions. And then also we will respectfully request Prof. Maresseau to give maybe a concluding remark, even in French, that you summarize what you said just in French, so that the French audience also can actually understand that. So that's what I wanted to add. Thank you.
Prof, would you like to start with a summary in French first?
Okay, 1 minute. 1 minute of summary in French. Ce que j'ai expliqué depuis le début, c'est que lorsque l'on a créé l'Institut IRCAD, l'Institut IRCAD a été créé avec le concept de se dire que les progrès de la chirurgie viennent et viendront essentiellement des progrès en mathématiques, en computer science, en développement d'algorithmes, plus que des progrès du geste chirurgical en lui-même. Et depuis le début de la création de l'IRCAD, il y a plus de 20 ans, on travaille sur ce qu'on appelle la chirurgie augmentée. La chirurgie augmentée, c'est à la fois augmentation de la vision. Le rêve du chirurgien, c'est de voir plus que ce qu'il voit normalement. Et pour ça, il faut la réalité virtuelle, la réalité augmentée, et ça, c'est vous qui pouvez le développer, bien sûr. Ensuite, il y a comment on va augmenter le pouvoir de la main du chirurgien, et ça, c'est la robotique, ce qu'on appelle laparoscopique par chirurgie mini-invasive, robotique pour l'endoscopie flexible que vous passez par la bouche, par exemple. Et ensuite, la troisième chose, c'est comment on peut augmenter la puissance du cerveau du chirurgien par l'intelligence artificielle, comment améliorer bien sûr sa stratégie diagnostique avant l'opération, et ensuite comment améliorer sa stratégie pendant l'intervention chirurgicale elle-même. Et ensuite, le tout est combiné, c'est-à-dire que la robotique de demain, le robot de demain, il va intégrer l'intelligence artificielle, il va intégrer l'imagerie en 3 dimensions et donc la possibilité de réalité augmentée en vision, en transparence. Et j'ai terminé en disant que dans ce que j'appelle la globalisation, puisque c'est extrêmement difficile, c'est aussi difficile en Europe et en France d'avoir des équipes extrêmement solides dans ce domaine. On a décidé il y a quelques années de globaliser l'équipe, c'est-à-dire de faire, il y a l'équipe française bien sûr. Là pour l'instant, on avait l'équipe à Taïwan qui travaille aussi énormément sur les mêmes domaines de recherche. Et plus récemment, il y a 2 ans, on a commencé à créer une équipe en Afrique, à Kigali, où on a des gens, le prochain PhD d'ailleurs vient du Cameroun, il ne vient pas du Rwanda, mais donc une équipe africaine. Et on collecte, on a 2 systèmes, on collecte des fonds à la fois en France, mais également au Rwanda, pour pouvoir financer plusieurs salaires de chercheurs, développeurs, notamment en intelligence artificielle appliquée à la chirurgie. Et on pense que dans l'institut qui va ouvrir en juillet 2021 à Kigali, qui va être le plus gros institut au monde dans ce domaine de chirurgie mini-invasive, l'équipe qu'on veut créer de 40 chercheurs en Afrique, plus l'équipe de Taïwan, plus notre équipe en France, eh bien, il en résultera certainement la plus grosse équipe dans le monde travaillant sur ces domaines de essentiellement intelligence artificielle et développement de la chirurgie de demain. Voilà, et je répétais que j'ai été séduit. Moi, j'avais jamais été en Afrique. J'ai été séduit lors de mon premier voyage il y a 2 ans, où je sais que le président Paul Kagame avait envoyé la ministre de la Santé et l'ambassadeur du Rwanda en France visiter l'IRCAD en France. J'ai eu ma première visite et première discussion avec le président Kagame. J'ai été impressionné par le niveau et la vision de ce chef d'État et la manière dont il a transformé le pays après le génocide que tout le monde connaît d'il y a 20 ans, et c'est la raison pour laquelle toute l'équipe vraiment fait ça avec un réel plaisir. Mon petit résumé en français.
Are you good? Are you good now?
Yeah, no problem.
We just need to pick, please, just a quick questions. We can see some fantastic questions coming in. If you could just do it in like 20 seconds. How long does it take to train people to master the use of the system?
It's long. No, it depends what you say. If it is computer scientists to use the software and algorithm, it is approximately 1 month. If we speak about the surgeon, how to adapt with a new technology, with a 3D modeling, that is, perhaps 1 hour. And with a robot system, it is so intuitive. So that is 1-2 days of training is absolutely sufficient to do that. For minimal invasive surgery, it's more complex.
Okay. And what about the margin of error? Before using the normal surgery and now using robotics, can you give us insight to the margin of error for both?
I have
the margin of error, like what's the likelihood of something going wrong?
That is a good question. So we can today. the goal of the next generation of surgery is to do absolutely zero complications. That means no complication. Today, you know that is impossible, but every year you decrease. But even for a very simple operation like the removal of a gallbladder, that is what we call a cholecystectomy, very simple operation. In United States, you have per year 5,000 severe complications. Severe complication. That means some of these patients, they lead to the hepatic transplantation. So even if it is only 5,000, it's a big economical problem. So the next generation of robotics, not this one, but the next generation, integrating artificial intelligence, you will have so many alarms. So that means if the computer see that the surgeon follow a strategy that he has never seen before, because he will have integrated inside thousands of operations, immediately you will have an alarm. So it's exactly the system today of aeronautics, for example. So I'm really convinced that the next 20 years will be a total change in the safety of surgery due to the development of your science.
Perfect. Absolutely fantastic. Thank you so much. You've definitely started the day off with a bang, so we can't appreciate you enough. Professor Jacques from IRCAD France, IRCAD France, he's the president there, and he's been giving us what is supposed to be the future of surgery and a new hope for Africa within that same domain. Prof, I can't appreciate you enough. I told you yesterday that studio was absolutely phenomenal, and you've definitely shown us how to use it properly. Thank you. Yes, I see. I see. So please, for the interest of time, just allow me to ask everyone to jump to the sessions. This first session is done, so please just go to sessions, and then we'll carry on with the rest of the program. Prof, thank you very much.
Thank you very much. It was a pleasure.
Fantastic. Please, everyone, let's just go to session.